Iron deficiency anemia affects 1.2 billion people globally, often presenting with nonspecific symptoms like fatigue or cognitive impairment that can delay formal diagnosis. The laboratory indicator for this condition is microcytic anemia, defined by a mean corpuscular volume, or MCV, of less than 80 femtoliters. A low MCV initiates a specific differential diagnosis. While iron deficiency is the most common cause, the differential also includes thalassemia, anemia of chronic inflammation, and sideroblastic anemia. A low MCV on a complete blood count is a requirement for further investigation. It is not an indication to begin immediate iron supplementation. Prescribing iron for unconfirmed microcytosis carries significant risk. In patients with hemoglobinopathies like thalassemia, exogenous iron can lead to systemic iron overload and organ damage. The diagnostic pathway must be completed to confirm the underlying cause before any therapy is initiated. Treating a low MCV without a definitive diagnosis is a clinical failure that exposes the patient to unnecessary physiological harm. To assess iron status, the definitive index is serum ferritin, reflecting total body iron stores. This spectrum illustrates the ferritin continuum. For absolute iron deficiency anemia, the threshold is specific. A level between 15 and 30 micrograms per liter confirms the diagnosis. This lower limit is highly specific for identifying true iron depletion in healthy outpatients. However, ferritin is also an acute phase reactant, meaning its concentration increases during systemic inflammation, regardless of iron stores. This creates a diagnostic challenge in patients with heart failure, chronic kidney disease, or inflammatory bowel disease. In these populations, chronic inflammation can elevate ferritin into the normal range, masking a functional iron deficiency. To resolve this ambiguity, clinicians must measure fasting transferrin saturation, or TSAT. When ferritin is in the gray zone, a TSAT of less than 20% confirms that the patient has insufficient iron for erythropoiesis. Utilizing ferritin and TSAT in tandem provides the precision necessary to identify iron deficiency across different inflammatory states. Relying solely on a standard laboratory reference range for ferritin in chronically ill patients results in misdiagnoses of severe functional anemia. Once confirmed, the physician must shift from diagnosis to etiology. Iron deficiency anemia is a clinical sign of an underlying process, not a standalone diagnosis. Root causes fit a 4-quadrant matrix. Decreased intake involves restricted diets. Decreased absorption occurs in conditions like celiac disease. Increased loss is a critical concern in adult men and postmenopausal women. In this demographic, iron deficiency is associated with occult gastrointestinal malignancy, including colorectal cancer. This association mandates bidirectional endoscopy, both upper and lower, to evaluate the gastrointestinal tract for sources of chronic bleeding. Finally, increased demand identifies patients whose iron requirements have exceeded normal intake, common during rapid growth and pregnancy. Maternal health guidelines utilize specific risk factors to identify patients who require more frequent screening to meet these physiological demands. Supplementing a patient's iron without identifying and treating the source of loss is a diagnostic failure that allows underlying diseases to progress. A frequent management error in clinical settings is prescribing oral iron supplements 3 times daily. This dosing schedule is based on the assumption that more frequent intake results in higher total absorption. Total body iron balance is actually regulated by the hepatic hormone hepcidin. This diagram shows how hepcidin coordinates between the liver, the intestinal enterocytes, and the plasma. A single dose of oral iron triggers an immediate surge in hepcidin production. This hepcidin surge shuts down the ferroportin channels, which are the only pathways for iron to move from the gut into the bloodstream. This physiological blockade lasts for up to 48 hours. Consequently, subsequent iron doses taken within this 48-hour window remain in the intestinal lumen, unabsorbed. This unabsorbed iron causes gastrointestinal toxicity, resulting in constipation and nausea, without contributing to the patient's iron status. Current evidence-based protocols recommend dosing oral ferrous salts once daily or on alternate days, often combined with vitamin C. Aligning therapy with hepcidin physiology improves fractional iron absorption while reducing the side effects that frequently lead to patient noncompliance.
Oral iron therapy is considered unsuccessful if a patient cannot tolerate the side effects or if the hemoglobin fails to respond after a trial period. In these cases, the algorithm moves to the secondary tier, intravenous iron formulations. Intravenous iron is indicated as first-line therapy for patients with absorption barriers, such as active inflammatory bowel disease or history of bariatric surgery. There are also temporal requirements, such as late-stage pregnancy beyond 34 weeks, where rapid repletion is necessary to optimize delivery outcomes. Recognizing the limits of oral absorption early in the treatment process prevents the use of ineffective therapies in patients who require parenteral repletion. After initiating a treatment plan, clinicians monitor specific markers to confirm therapeutic success. This timeline tracks the recovery of hemoglobin and the replenishment of ferritin stores. The initial milestone is an increase in hemoglobin of 1 gram per deciliter. This increase should be observed within 2 to 4 weeks of consistent therapy. A common management error is the cessation of iron therapy as soon as the anemia is corrected on the blood count. Hemoglobin normalization indicates that there is enough iron for red cell production, but it does not mean the body's long-term reserves are filled. Patients should continue oral iron supplementation for 4 to 6 months after their hemoglobin has reached the target range. The objective endpoint for stopping therapy is a ferritin level maintained above 100 micrograms per liter. The clinical management of iron deficiency is only complete when the anemia is corrected, the underlying cause is addressed, and the physiological iron reserves are fully restored.